type 1 diabetes is incurable disease, and it needs a long life or lifelong treatment. And the question is there a hope for curing type 1 diabetes? Professor Mick Kumwenda will talk about challenges in the cure of type 1 diabetes. Professor Mick.
Thank you. Thank you very much, Chairpersons. Absolutely thrilled and humbled to be taking part in this last session of the day, and very much appreciative for inviting me to come to Cairo yet again. So, challenge for me is to chat to you about whether there is actually a cure for type 1 diabetes. We've already gone through a lot of epidemiology. So, next slide. Okay. Still not moving. Okay. Right, so this is the summary of what I'm going to do. Talk about epidemiology, just a few seconds about what we've learned and which way it's sending us to go and concentrate our efforts. Mechanisms of early failure of beta cell destruction, current and future therapeutic options for the treatment of type 1 diabetes, and how far shall we go in the future. You already know the epidemiology about the problems, and this is showing us, in fact, that in type 1 diabetes, i.e. those patients, children and adolescents, and we've had different definitions earlier on in the sessions, but for the IDF, we're looking at, for this data, we're looking at patients under the age of 20. You can see actually the top 10 countries that have problems with youngsters with diabetes. So United States, India, Brazil, China, top in the league tables. 35% of the children and adolescents in type 1 come from the top 3 countries. So this is telling us something. There is something about the population in those countries, and also there is something about the environment in those countries. Otherwise, the prevalence would be the same throughout the countries. But you can see the other countries, actually the prevalence is quite similar. So what is it these countries have in common that's triggering these factors to lead to type 1 diabetes? And then if you look at the number of these type 1 diabetes under the age of 20, again, mirroring the adult population data that we've seen already. So if you look at the MENA regions, there's lots of type 1s there, which is, if you look at the prevalence of diabetes in general, these countries, apart from the African continent, they already have high prevalent levels of diabetes, including adults. So let's look at the league table for type 1 diabetes. And this is countries throughout the world. And you can see, I hope you can see from the back, but right at the top of the list, you've got Finland, you've got Sardinia, you've got Sweden, and you've got Poland, and then the UK. So very high prevalence in those countries. Now, if we just take Sardinia as an example, so even within Sardinia, there is a geographic difference. So in yellow, the prevalence, the level risk of diabetes is 0.95 to 1. In white, at the top of Sardinia, is 1 to 1.01, and then the highest prevalence, which is in red, is concentrated here at the bottom. This doesn't actually show. I'm not sure. At the bottom here of the country. So around the world there is a difference, but even in the same country there's also a difference. So what is going on? Let's have a look. Now, these are the natural antibodies that have been found. These are the things that we know about. There is some genetic susceptibility to type 1. And you can see on the left there, does this pointer work here? Doesn't. You can see them, there's those factors related to genetic susceptibility. There are factors related to islet autoimmunity, and then there's factors related to hyperglycemia and factors related to diabetes onset. So the genetic ones are the primary causes of type 1 diabetes. Then there's the secondary. There's something that's causing stimulation of these antibodies. And then the outcome of that stimulation is the destruction of the pancreas, and therefore hyperglycemia as secondary. And then you've got problems. Once you have had diabetes, then diabetes then leads to complications. So there are areas where we can intervene with therapeutic options, right from the beginning of genetic stability to the actual production of diabetes as an illness. And this is what's happening. You've got here a period of time when the autoantibodies are stimulated. They are actually positive. They haven't done anything to the pancreas, but they're there. The question is, does this run in families? Can you predict which ones of these children that have got autoantibodies are therefore going to stimulate killer cells to destroy the beta cells, then produce diabetes as an illness? So there is some kind of inflammatory reaction that is causing pancreatic cell destruction, i.e. there is a period of insulitis, and therefore this is a target area for therapies in the future, because by the time they've now switched on the diagnosis of diabetes, it's very difficult to reverse that for the type 1 diabetes. So we have those opportunities to intervene. And I think you've already seen this cartoon earlier on, and the proposal is that at the beginning of the patient's journey, when the autoantibodies are being produced, that's called stage 1, and then stage 2 is when there is now beta cell destruction, and that then produces hyperglycemia. They are still symptomatic, and that's stage 2, and then stage 3 is when you do develop symptoms. So the question is, if we can identify these patients, so if the running families, those families that have siblings or parents with type 1, and then they have children, you can monitor their autoantibody, and then can you predict which ones are going to start destroying your pancreas, or their pancreas? And then out of those, can you predict which ones are going to actually develop overt diabetes? And we know once they have antibodies, the chances of developing diabetes over the next few years is actually quite high, at least 80%. So here is what happens, and I haven't got time to go through this too much detail. But basically, you have dendritic cells in the pancreas that release antigens, antibodies. There's nothing is happening there. The production starts, and then you have activation of their CD4, and that produces antigen-specific B cells that then develop autoantibodies. Some of those antibodies then combine with macrophages and become killer cells, and then start destroying the beta cells. We got no idea how this process happens, but nevertheless, there are 3-4 areas there that you can target the therapy. And then simplify this, you have activation of the macrophages, and then some of those macrophages can then lead to the induction of T cells to produce chemokinase and cytokines, and that then causes destruction of the beta cells, which then die. And when they die, they obviously can't produce insulin. So you've got in blue there, this does not project very well. You've got the autoantigens. So you've got insulin glutamic acid decarboxylase, you've got islet cell antigen, you've got zinc transporter, and so on and so on. And then you've got the immune cells, the CD4 T lymphocytes, macrophages, dendritic cells, regulator cell, Tregs, and natural killer cells. So you have the autoantigens, then the immune cells become active, and then the whole process continues to lead on to beta cell destruction. So where our research at the moment is that in the primary prevention era, there's not much that's happened there. You know, we've probably tried oral insulin. The results were promising at animal level, but not translated into clinical therapy. So at this point in the primary prevention, then the main thing we can do is to identify these children, mainly because of the family history they have. So we can identify that they have this problem that they may develop. And then in the secondary prevention stage, then once you have identified those children, you follow them up and then you check their antibodies. When they've got the antibodies are not causing any problems, that stage you can then do quite a lot of studies. Some of these, and I'll show you one or two in a minute, some of these have already been started to try and tackle this area where the antibodies stop becoming active and working with the T cells to produce these dendritic cells that then go on to produce chemokines that will destroy the T cells. Then, of course, if we are not very successful at that point, then we still got an intervention at tertiary prevention, and then you can then use immunosuppressive agents to try and control the disease. But nevertheless, I think this is still quite a research area. So here is a study that's been published in Diabetes Care and looking at teplizumab, which is an anti-CD3 antibody treatment to preserve C-peptide responses in patients with new-onset type 1 diabetes, randomized controlled study. So 6 centers from 2005 to 2011, 52 patients aged between 8 and 30 with type 1, and then they had antibodies, the GAD65 antibody measured. And then for these patients, they were given teplizumab 50 to 826 micrograms per millimeter cube, per millimeter square. So we had patients' demographics, BM, C-peptide antibodies, insulin use, and HbA1c. Similar demographics of the patients that were studied in this group. So you can see in red is your intervention, which is the teplizumab, and in blue is the control group. And over time, over a period of time, you can see the C-peptide, maintenance of the C-peptide, i.e. the ability to produce insulin was maintained over time, showing that actually you can slow down the production of diabetes as a condition. And this is just looking at the responses depending on whether they were responders to the drug or non-responders. The non-responders didn't do as well. The responders actually did pretty well in this cohort of a study. So how does this all work? I think this cartoon is telling us what I have shown you earlier on, that in fact you have sleeping killer cells that are no threat to beta cells, and then something wakes them up, so triggers something like a bacteria or a virus, and then they start dividing rapidly to attack the beta cells. So this has been published in the American Diabetes Care, and I've taken this from the ADA website, showing us the stages of diabetes where these trials are being focused. And the group of centers that have come together to look at this problem has formed this TrialNet network. And they are, at the moment, doing several different studies. And I've already mentioned that the oral insulin has already been published in animal studies. Then we got the betasept and teplizumab. I've already shown you the results. And then there's all these other things that are being concentrated in the stage 3 of the condition. And most of these are immunosuppressive agents. I've described teplizumab, and then there's others called canadimab. Then there's the metabolic control. So there's a lot of studies that this group will be showing us the results in the next future to see how we can control the progression from vulnerable, susceptible children to the development of diabetes. So how far do we go? And this came up on the BBC website about Douglas Melton. What's going on? Douglas Melton, who is the co-director of the Harvard Stem Cell Institute, about the award he was given for research in the use of stem cells in animal studies. And he has actually got 2 children with type 1 diabetes. And one of them, was, taking, saying to him, well, why are you getting so excited? It's taken you 8 years to get to this stage, and you still can't cure my diabetes. So why should we celebrate that? But nevertheless, I think this is where it's going. So I've shown you the cartoon about the TrialNet, and I think there are centers now, they're looking at stem cell as the next stage of therapy. And I haven't got time to go through this in details, but what they've done is to actually grow some pluripotent stem cells, put them into the pancreas of an animal, and then they take some more of the antibodies that they have produced, and then to try and use those to reduce the development of diabetes in susceptible animals. So I'm sorry we haven't got time to go through this, but these guys have done is that using stem cell, you can protect the pancreas from vulnerable attack from the autoimmune process we have gone through. And this is the group of the TrialNet. Initially, there were only about 16 centers, but I know within a couple of years they become 25, and there are still some more being enrolled into a huge international network to try and understand the natural history of type 1 diabetes and working out what are our therapeutic options. So if we go back to the first questions, have we got a cure for type 1 diabetes? And I'm sure you already know the answer to that. But don't forget, we built the pyramids, so nothing is impossible. All right? So with that note, Mr. Chairpersons, I will stop there. Maybe we've got time for 1 or 2 questions.